come, and we want to start the session. Professor Hisham, Professor Jose Karam, Professor Maya Dean, Professor Ahmad Hamada, Professor Ahmad Salim. So we'll start now, please.
Bismillah ar-Rahman ar-Rahim. First of all, I want to thank Professor Hisham Al-Ghazali for inviting Dr. May and me for this job. Actually, we'll start the fight, but I'll keep the first part of the fight for Dr. May.
Bismillah ar-Rahman ar-Rahim. I'm really happy to be here today, and I think it's the first MDT, in my humble knowledge, to discuss a prostate cancer consensus. If anybody has any other idea of something different, and always Dr. Hisham Al-Ghazali is an innovator and pioneer to suggest something new like this in our region. Of course, the talks have been excellent. I would like to thank everybody and about all the excellent talks and coverage on the subject. We know the incidence of prostate cancer. We should be aware that in Egypt, the incidence is expected by 2050 to quadruple. Different geographic areas and ethnic variations also have an incidence effect on the disease. So we have guidelines, but why do we need a consensus? Why do we need to sit and talk together and have this interaction? It's fruitful. It's peer reviewed effects. We can talk to each other, we can discuss the different points of view we have, we can discuss the studies. It only serves to move us forward in shady or gray areas not adequately covered by the evidence or the guidelines. And in the end, we know that we are sitting in the clinic with the patient. Perhaps an expert-guided opinion would help us only move forward to know the best sequence of treatment for this patient. I quote this from the first Advanced Prostate Cancer Conference held as in most consensus conference traditions in St. Gallen, Switzerland, that in the absence of evidence, selection of treatment is based on clinical judgment that includes the experience of the treating physician with available agents, the status of the disease, and when the patient is presenting for treatment. And of course, we have to take into consideration potential comorbidities that might preclude a particular treatment, even if it is supposedly the best in that condition. Of course, the best solution would be to have a clinical trial, but it's not always possible. So that's why a consensus is the next, or perhaps the best thing. I would like to thank all our panelists here, and here are the names. And so we'll start. Do you have it? We'll shoot away. Sorry if you're, could you put your hands up, or it's okay? So, a very debatable subject indeed that we are starting with the first question. To be or not to be, to screen or not to screen. Would you recommend screening in prostate cancer? Number 1, yes. 2, no. 3, abstain. I'm not sure. Is the timer working, or the results are? It's working?
Yeah.
So the answer is number 1, yes. But I want to stress that not all the cases or not all the population needs screening. Screening should be reserved only for high-risk population. So any comment about this?
I want just to mention something important for the panelists, that these questions will show the trend of the panelists here from the region and from Egypt and also from the United States by Professor Jose Karam. And we want maybe to publish these data if we feel that it is important to publish, and this the Egyptian opinion about this very important subject. So it's very important for all the audience to hear from the panelists here for this important scientific message. Thank you.
Thank you.
Comment about this? This is a very, very difficult question to answer. Right? And I don't think even we had a definite answer for this even in the most westernized communities. But I believe, to cut it short, do not take it, if somebody is arguing against screening prostate cancer in Egypt, we should go for screening for prostate cancer, because we do not have the what do they call the option or the advantage of culture, educated people, educated patient that could go for a true shared decision making with him. This is my point of view. So it's very hard until we have a very developed community and until we have a population who can be oriented very well with the current knowledge, and when the media is not biased, etc., 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 and they could have their own understanding and level of thinking. At this moment, we should, until this moment, we should go for screening to bring this patient, and we, unfortunately, unfortunately, we should decide for them rather than do a decision making.
Can I ask Professor Karam to comment about this, and what is the strategy in USA? About screening?
I'd like to stress about the term screening is applied to asymptomatic persons. But personally, I prefer to do this screening for patients with lower urinary tract symptoms coming to our clinic. This is what I mean by screening for me. For a patient with lower urinary tract symptoms above the age of 50, starting from 50 years, okay? And I'd like to stress very important practical point actually is to do at the start BSA total, simply. There is a tremendous abuse of the BSA, of the free BSA. Despite I write and put stress about the total BSA. All the labs do for the patients total and free. Even in those patients with prostate cancer, and they very, very, very strange. And I'd like to be a message from here to reach our colleagues in the clinical pathology. Please don't abuse this free BSA. It's nonsense to do BSA in a patient with the BSA below 4 or above 100. This is very strange. This is very strange. This is the 2 points I'd like to stress.
Did you want me to comment? So, I mean, by definition, screening, it should be for anybody. It shouldn't be for patients only with lower urinary tract symptom. And the other point, at least, and I know there is definitely cultural differences, and I come from Lebanon as much as I come from the United States, but we can't really make a decision for our patient. I mean, even if they're not well educated, we still have to tell them that why we're doing the test, what we're checking for, and what might happen if the test is quote-unquote positive. So we at least have to explain to them, and if we can't explain to them, it's our fault. We should do better to explain to the patient why we're doing this and what prostate cancer is and why we're screening. And I know in the U.S., I mean, the U.S. Preventative Task Force, they recommended against screening for prostate cancer. They were based mostly on the PALCO study, but as you might have seen 2 weeks ago, there is new data that showed that patients in the non-screening arm actually had more PSA testing than the patients in the PSA screening arm. So the data is very contaminated. So then now they're reviewing to see what the new recommendations are going to be. So I was one of the 6 people who said yes, but I think we should have a discussion with the patient why we're doing it and what we're doing.
Just a comment, if you ask this question 10 years ago, I think most of the panelists will say yes, but we know the data, there is controversy whether to do or not to do. But for our patient in this region, I think we'll do that like not only as a screening, but awareness, because our patients, they don't go routinely to the clinic. Even our clinicians, they don't do digital examination. So I encourage you to do PSA for the patient who are above 50 as a form of awareness, not screening.
Thank you. Second question, radical prostatectomy versus radiation therapy for localized prostate cancer. First choice surgery, second choice radiotherapy, 3 abstain.
Is there active surveillance there?
Which stage?
I moved it. Just localized prostate. I didn't, just general. No. Just a general question. If the patient is, okay, not for active surveillance, which I just wanted to see which modality you would prefer.
Start voting?
I think it is important to rephrase these statements to be more logic. I don't know if Jose.
Maybe we can say.
We must suggest something
as a suggestion, of course. Yeah. Radical prostatectomy in patients who do not want active surveillance or who do not qualify for active surveillance, and they have localized disease. What would be your treatment choice?
What localized?
I'm not sure.
So if the patient asks for active treatment or the patient needs active
yes, patients eligible for curative treatment.
Yeah. So may I ask Professor Tariq Osman?
If this patient is not willing for active surveillance, refuse active surveillance, if we should first know what is the risk of the disease. If he's a very low risk, I will offer him an active surveillance. If he's a low risk, I might put his choice for active surveillance versus curative local therapy. If he is surgically fit, have a good lifespan, not have a morbidity, I will go for surgery. Otherwise, I will go for radiotherapy.
So we can we vote again for Albert? Can we vote again for this question according to the statement raised by Professor Jose? We can vote now.
Yes, number 2.
So we can vote now. It's okay. So I'm asking Albert again to vote again because I think most of the people here are not catching it to vote. Can we vote again, please, for the previous question? No. Okay, start now. Start now, sir.
Yeah, there is always a difference between the low risk and intermediate risk.
Okay.
So, and even the high risk patients, all the 3 are put under the localized prostate cancer. So it's the question is not perfect in its phrasing.
Can I have a comment?
I'd like to add something. There is an very low, there is also a very low. In 2016, the CNNC guidelines put very low, and very low is just for watchful treatment. And the life expectancy is very essential if it is more than 10 years, and actually there is survival benefit behind 18 years of age, so surgery can be done in such select cases with no comorbidity and low surgical risk.
Actually, we don't have life expectancy chart here in Egypt, so this is not available.
Excuse me. Dr. Albert. Okay. Actually, if the patient, all the parameters are good and the disease is within the prostate, does not touch the capsule, and the surgery is very possible, I always vote for surgery, because really nothing can get rid of this cancer apart from surgery. But the argument is in the guidelines and in the clinic that radiotherapy needs high dose, but it's offered for patients who are not capable to undergo surgery without major complication or without addition of post-operative radiotherapy. So if the patient is fit and the disease is small, for sure, even the NCCN, the European Association of Urology, all raise the possibility of surgery first. But if there is the other parameters are not consistent, we may ask for consider radiotherapy.
I'd like to ask a question for radiation therapy group. Okay.
I just want to be sure. Are you saying that surgery should not be done in patients with capsule infiltration?
No, I totally agree. And the extension of the indication of surgery now is extended even in some selected cases of locally advanced. But for comparison of the cases of the disease within, away from the capsule, it's by far no argument that surgery is better. But in cases of the touching capsule, we will discuss whether this is bilateral capsular infiltration nearby the neurovascular bundle. All the bundles are touched. What about the capabilities of the surgery? What about the complications? What is the chance of R1 or more post-operatively when the patient will need adjuvant radiotherapy? All these parameters might be. Yeah. So
it will be multidisciplinary discussion. Yes. That the patient might need surgery plus radiation as well. One might not be enough either.
Yes, for sure. Double modality is not wise decision. But in the early cases, for sure, I would vote for surgery. But other cases, we may weigh and balance all parameters in comparison.
So we can conclude from this for a statement that the decision of radical prostatectomy versus radiotherapy in localized prostate cancer must be done in MDT?
Yes, just a comment to Hisham. The guidelines clearly, NCCN guideline and the AOA and the EOA as well.
We want to go for our recommendation, Professor Gamal. It is not. Yes, we are not discussing the other guidelines. We want here to know our opinions as an experts here in the region, to put our opinion. So for your opinion, it is better to go for MDT approach between the urologist and the oncologist to decide the radical prostatectomy versus radiation therapy, or you want to go for one strategy from the start?
Both are valid option. Okay. There is no contraindication for this or that. You choose based on the age, on the risk factors, and the availability of the high-tech radiation therapy or not. Data is very clear in all guidelines that both are equal. We don't have any randomized study that showed which one is better than the other. So this will be based on the skills of the oncologist, the skills of the radiation oncologist, and as well as the urologist, who can remove all the lymph nodes, not doing radical prostatectomy and removing only 2 or 3 lymph nodes. I know with the new technology in radiation therapy, you can give very short of radiation therapy now. Instead of the 8 weeks, you can give 4 weeks now in the low risk and intermediate risk, as well as all the radiation in the surgery. We know that the robotic surgery and laparoscopic surgery is less morbidity. So both choices are valid, and you can prefer radiation therapy in a country like Egypt because the cost is very much cheap. Here, you have patients who can be treated only. We know that the course of the IMRT in private center in Egypt costs not more than 10,000 Egyptian pounds. When the cost of the radical prostatectomy or laparoscopic prostatectomy will cost, how much the patient will pay. So the center of care call for both modalities. You choose what you have the staff to adapt this modality.
So according to the MDT. Yes. The third question. Extent of lymph node dissection in patients with localized prostate cancer. Extended, first choice, second choice, limited.
Start the voting, please.
A majority, 57%, voted for limited pelvic lymph node dissection. Would the urologists like to comment?
Yes, هو the standard of care now is to do extended lymph node dissection in a high risk group. In intermediate risk group, it is much preferred. In low risk group, it's not needed.
Sometimes on further lymph node dissection, patients are actually upstaged and positive lymph nodes are found, I think.
The essence of surgical intervention is to offer the patient curative line of treatment. For this, extended lymph node dissection is the standard now. And I'd like to add one point regarding also lymph node dissection. In the past, we abandon if we do frozen section for the patient, and if the lymph node is positive, we aborted the procedure. Now this has been also changed, and they recommend completed radical prostatectomy, even in the presence of lymph node positive, is better than to abort or abandon the procedure. So frozen examination of lymph node is not needed now. We just depend upon the stratification, whether low, intermediate, or high risk. Another point, I think that the intermediate risk group, those are the group who get much benefit from surgery. The low risk, it's low risk. It can offer the deferred treatment, watchful waiting, or active surveillance. The higher risk, we know that if there is extra capsular, about at 5-year post-surgery, if it is in the high risk, about 50% relapse of the BSA. So the most important group actually is the intermediate risk group that get benefit from surgery.
Will not change survival. Yes, sure. Prognostic factor, but will not change survival.
May I? Yes. Kind of, not that much.
Important point in the survival. I think now all guidelines recommending extended lymphadenectomy for two reasons. Because 2 trials proved survival benefits, but yet we cannot consider. But the most important about the extended lymphadenectomy, that it tells us how much of nodes are being infiltrated. Because we know that addition of ADT after 1 node or 2 nodes positive in the lymph nodes dissected improves survival. This is the major benefit of extended lymphadenectomy, that we will add ADT that will save lives, as Dr. Hisham Ghazali save lives. So this is the importance of extended lymphadenectomy.
Thank you. Yes, sure.
I think if the patient is really risky enough to need surgery, they should undergo extended node dissection. And I think when they have 1 lymph node positive and we only removed 5, we don't really know how many others there are. But if we removed 50 and there's only 1 positive, sometimes these patients, if the PSA normalizes, we don't give ADT. So that's another debate. But I think if a patient is high risk enough, they should undergo extended lymph node dissection.
Jose, you are the chair for this session, so please direct the session to try to go for we try to go for a conclusion from this these statements, and I hope to go for like a manuscript or something. So I hope that you can manipulate the discussion as much as you can.
Fourth question. Radical prostatectomy ideally should be laparoscopically done. First choice, yes. Second, no. opting for open. Okay, 71 majority.
May I on this, please? Ideally, now the standard of care is the robotic prostatectomy. Now, almost, for example, in the States, almost 75% of all prostatectomies are carried out robotic. Because we are talking about Egypt, since we do not have, I believe, till now, this moment of time, we do not have this volume of cases that could provide us with a good learning curve in laparoscopy. I think we should, until we have this volume, we should go for the open technique.
Professor,
we can discuss it after this question.
Okay.
Prostatectomy is an acceptable alternative to the more traditional approaches. Majority said yes, of course, 83%.
It's not available in Egypt.
Unfortunately.
Your comment, Professor Jose?
Yeah, so I think if a robot is available and the surgeons using the robot have experience, it should be done robotically. But in hospitals that don't have a robot, they should still do it open if that's what they're experienced in. Ultimately, it's the experience of the surgeon doing the surgery more than the technique. So if a robot is available and people know how to use it, sure, robotically. Same thing for laparoscopic. I mean, a lot of places in Europe, they still do it laparoscopic, and that's perfectly fine if that's what their experience is. And if they don't have a robot, doesn't mean that everybody should buy a robot just to become better. If one is available, sure, use it. If you are expert in open surgery, it's very much okay, perfectly fine to do open surgery.
May I have added a comment? If, as high volume centers and well-experienced surgeons with minimally invasive techniques should be done as minimally as possible. This is for the sake of the patient.
Sixth question. Would addition of short-term ADT to salvage radiotherapy given for biochemical failure be beneficial? Yes.
After radical prostatectomy.
After radical prostatectomy. Oh, yeah.
Biochemical PSA only.
We start now to vote. Yes.
Post-radiation and ADT
Together,
after
combined.
failure of surgery.
So we know the standard we give salvage radiotherapy. Can we add ADT to achieve a better benefit? I think there was a trial that's for 6 months.
Yes.
French trial, one of the GTUG.
Yes. هو البايوكيميكال فيلير افتر radical prostatectomy يعني بيبقى عندنا tendency to distinguish between whether this is a local failure or a distant failure. If this failure within the first 12 months, if there is N positive in the histopathology post-operative, if there is Gleason 8, this is in favor of the distant mets. And in this scenario, the ADT will be preferable. If it is beyond the 12 months, there is extracapsular T3A, locally advanced disease in the specimen post-operative, and the BSA7, it's in favor of the local failure. And in this scenario, salvage radiotherapy will be of benefit. And now the multiparametric MRI, I think, will be helpful to recognize the local failure. Okay.
I have a short comment, but there was just data published from the ASCO Genitourinary Symposium, I think, this year. And I have like a comment about short term because they used bicalutamide for 2 years and it was positive. We are waiting for full paper, but from the abstract it's clear that it's positive. And it's very important to know that there is synergistic effect between radiotherapy and hormonal treatment, whether it is bicalutamide or whether it is an LHRH agonist. So I would just have to change the word short. There may be an addition of androgen deprivation treatment with radiotherapy, and we have to wait whether it is for 2 years or for something else. But for short term...
So there could be other drugs addressing the time, short or long, ADT.
But this will take years and years. I think what we have now, we are waiting just for the full paper to be published, is 2 years of bicalutamide with radiotherapy.
Thank you. Seventh question. Immediate as opposed to deferred, ADT may improve long-term overall survival at a small quality of life cost in men with rising PSA after curative treatment.
Start voting, please.
Majority said yes. Almost, I think, 80%. I can't see.
To how long, though? Like, what would be the criteria to start what PSA level?
It's coming up in later questions. Yeah. In treatment of metastatic prostate cancer, would initial ADT with bicalutamide 150 mg monotherapy versus castration be your choice? First choice, bicalutamide. Second, castration. Third, abstain. Voting. Majority is with castration. 66.7%.
But I think the question should be reformulated, because you are saying whether you choose for bicalutamide as a monotherapy versus castration be your choice. I mean, both are equal. I mean, we have bicalutamide 150 milligram that can be considered for patients who would want to preserve potency, and you have the choice of castration, so I wouldn't put it like a choice rather than we can put it an option.
Patient-doctor discussion.
Yeah, it can be an option for patients.
هو bicalutamide alone is not an option for metastatic ovarian cancer. Castration is the standard of treatment.
Yes.
So we have data for 150 milligram to be equal, not for the 50. The 50 was negative, and then we raised the dose to 150.
I know, yes. But still the standard is castration, not bicalutamide circulations.
But some European centers do offer their patients actually.
I know, but we are talking about the standard. The standard is castration, medical or surgical. This is only small data. You cannot just take it as a consensus.
choice,
If the patient is completely refusing castration, this is not the second option, but this is not head-to-head.
So 66% of the panel is going for castration, and I think we go for next question.
Medical castration with LHRH agonist is preferred to an antagonist. Yes, no, voting. No. 71%. 10th question. Advanced prostate cancer monotherapy is the preferred option than combined androgen blockade. Said yes.
May I?
Definite consensus.
May I? مش عارف أي واحد مش شغال. Actually, there is some benefit of a combination, but it's just a 5% benefit. This is the...
It's okay, very important. بس طبعا this is to be differentiated from combining anti-androgen at the start of treatment. This is a must. يعني
Question number 11. Do you recommend intermittent instead of continuous ADT in radiologically confirmed M1 patients that achieve an adequate PSA decline? No, most we have here 5.6 said no. We should go for continuous.
If you asked Mona this question 2 or 3 years ago, I believe it would have been much more in the favor of intermittent therapy. But just recently, we have some data that says that continuous might have a survival advantage than intermittent. Although, again, I don't believe that it's a huge difference. I think I personally till now prefer the intermittent therapy because there's a huge difference in quality of life and complications, whether starting from hot flushes to thromboembolic manifestations through to impotence, etc. And really patients, when they stop this LHRH analog, they really enjoy their life for the next 6 months. Especially
I think intermittent androgen deprivation failed in high tumor burden patients, so it should not be used for patients with high tumor burden of metastasis. But you can choose for your patient to be on intermittent if you think that the comorbidities for the patient from the androgen deprivation or long-term androgen deprivation treatment would affect his quality of life. But for high tumor burden should not be recommended because there is clear data of poor survival for those types of patients.
12. Do you recommend chemotherapy in newly diagnosed high volume, hormone sensitive prostate cancer? High volume as from the charted trial definition, as we've just seen in the presentation. I guess we'll know now who won in the debate.
We agreed both.
So, yeah, we are agreed both on this.
Can I make a small comment about this? Because in the debate I wanted to make this comment. Let's say we are putting 6 cycles of docetaxel with a cost of money of X. And I'm telling you that all our patients, whenever they fail in hormone and become hormone refractory, they will start chemotherapy. If you looked at the survival advantage of adding chemotherapy after the patient started to be resistant to treatment, you would buy something like 6 months or 7 months in the best hands. So if I'm telling you that I'm buying for my patients with high tumor burden 13.6 or 17 months of life, adding the same amount of money, but putting it just up front, we all know treating prostate cancer patients, they do fail after a certain period of time, whether it's years, whether it's months. So what I'm looking for it, if we are looking for the economic point of view, like in Egypt, I would put it like that in this statement. How many months would you buy with the same amount of money you are putting? If you are buying 6 months at the end of the patient, whenever he become refractory, so would you put it in the beginning with the same budget you have? Let's say you have this budget of 6 cycles of docetaxel. But the way docetaxel is not an expensive drug, as I can understand now, so would you put the same amount of money initially buying 13.6 or 17 months? I would do that. So I mean, if the survival advantage would be greater putting the drug up front, so why don't you buy it? I mean, we know that those patients usually they will go for docetaxel at a certain point. So this is how we are looking at things from the budget point of view as well.
I totally agree with you, Dr. Mustafa. Even so, using taxotere as a first line in the STEM-D or the chart is used only for six cycles. But using as a salvage, you have to use it for 10 cycles as per the tax study. As well as in the other studies, in the hormone sensitive, you don't need to use corticosteroids as well. So using docetaxel up front would be much better than deferring it at the time of progression.
Those who have the right to.
Yes. Do you recommend chemotherapy in newly diagnosed any volume hormone-sensitive prostate cancer? And I think the answer will be easy after the first question, the previous question. Let us vote, please. This is expected answer. So question number 14, do you recommend chemotherapy as first-line treatment for progressive metastatic castration-resistant prostate cancer? Please vote.
Can I ask my oncology colleagues a question?
Yes.
Is there any new data about the anti-androgen withdrawal phenomenon?
I don't know about trials or studies about the effect of withdrawal effect, and even if it was done before, it is expected to be only a few weeks.
So you know more. Do it in your practice.
Most probably no.
Do it if
يعني the anti-androgen withdrawal phenomena, we have to wait for 4 to 6 weeks to make apparent. And there are, by the way, also there are reported cases of withdrawal phenomena with abiraterone.
Yes, I think this question is I don't know. So you can tell that you recommend the chemotherapy as first-line treatment. So we have another recommendation. We can go for another options. So I'm afraid to be somewhat biased in this question. So you ask me to go for, yes, we can go for chemotherapy, but we can go for others.
Yes. We'll discuss this only in the next questions also. For the diagnosis and confirmation of M0 castration-resistant prostate cancer in routine practice, you will depend only on negative CT scan and bone scan, or you will add some other investigations. Please go.
والله مش لازم اقعد اشاور
هتعمل تفسير يعني حاجه بس اول ما يعني يشوف حاجه شغالين هنا
Number 16. Do you recommend PSA data, PSA level and or kinetics as a trigger for imaging in an asymptomatic patient with rising PSA on ADT and no known metastasis? So please vote. So let us move to next question. Question number 17. If you voted yes for PSA kinetics and level as a trigger for imaging in an asymptomatic patient with rising PSA, So which level and which doubling time do you recommend? BSA 2 or above, and BSA doubling time less than or equal to 6 months, BSA 10 or above, and BSA doubling time 3 months or below, BSA 20 or above, and BSA doubling time 12 months or less. Please vote.
May I have a comment?
Question number 18. Is it appropriate to extrapolate the results of COU trial epiritron acetate plus prednisone versus placebo and plus prednisone in chemotherapy naive castrate-resistant prostate cancer patients without visceral mets to chemotherapy naive patients with visceral mets? Yes or no, please kindly vote. Let us move to the next question. Is it appropriate to extrapolate the results of the PREVAIL trial and COU trial to symptomatic chemotherapy naive castration-resistant patients? Kindly vote.
Are they the same? I'm not sure I can understand the question. Is it a
just a comment?
For patients who are asymptomatic or with minimal symptoms.
Okay.
We can extrapolate the results to patients with symptomatic castration-resistant patients.
Uh-huh.
I think we cannot extrapolate between two different trials done with two different populations with two different time interval. I mean, we cannot extrapolate data between two trials. Whatever the results is. I mean, can we
need to reformulate the question?
Yeah.
But actually, we have data that patients, symptomatic patients, may benefit from.
Dr. Hisham, the answer to this question, the guidelines now accept these for symptomatic. The definition of mildly symptomatic is not clear. There is a study showing it taking asymptomatic plus mildly symptomatic. This is in the NZ, also in the epiritron study, both of them. But we're going to the NEC guideline, for example, they mention symptomatic, regardless whether it's mild or whatever the symptoms. So I think the standard is a patient symptomatic, you can use both of them.
I think it is important to, if you, as you said, we can reformulate the question without saying that we will extrapolate any results. It is just an expert opinion evidence. So if the opinion here of the evidence of yes or no is okay, without extrapolation, because most of the people here, I think, saying no because extrapolation. So we never extrapolate anything for anything.
Clinical trials, actually, we cannot extrapolate results from another trial to one trial to another. Question number 20, do you recommend epiritron or enzalutamide as first-line therapy for otherwise healthy asymptomatic or minimally symptomatic patients in addition to ADT? Please vote. Question number 21. I
think we need to comment.
Can we go? Oh, go ahead. لا تفضل. Is this after or before docetaxel therapy? I understood it's
very useful.
And would you think, is this the consensus that we do it in Egypt here?
Well, actually, we use docetaxel mainly in symptomatic patients who are not using docetaxel in asymptomatic.
Okay.
I think this is the data that we have. Yeah. Whenever the abiraterone and enzalutamide, when it started, they started to give it after docetaxel, and whenever they started to put it before, they put it in patients asymptomatic, and it makes sense because patient, he's asymptomatic, he's metastatic with just a PSA, just detected high PSA level, so quality of life would be much better if you put the patient on hormonal treatment rather than giving him docetaxel. And I think the NICE guidelines even approved, the only approval for
1 month before
enzalutamide before docetaxel was in such situation in asymptomatic healthy patients. So I think it makes sense. If you have enzalutamide or abiraterone acetate, you have the money to give it to buy it. So why not to do it for a healthy, non-symptomatic
But
patient?
as far as I know, Dr. Mustafa, they approved the abiraterone only, not enzalutamide. They're nice.
NICE guidelines recently approved enzalutamide pre-chemotherapy.
Not abiraterone?
They didn't approve abiraterone pre-chemotherapy. So if you want to give abiraterone acetate, you have to give chemo, then abiraterone acetate. So what we are doing now is to make it like a trick. So whenever the patient fail after, hormonal treatment, and he started to fail, we put the patient on enzalutamide to get away from the NICE, because this is the approval now. And then whenever the patient fail, we put him on chemotherapy, then we shift on abiraterone acetate. So it's like going, so that, because if I started by abiraterone acetate, or I started by chemo, and then abiraterone acetate, and then I tried to put him on enzalutamide, they will refuse to give it to me. So the only approval for enzalutamide is pre-chemotherapy in healthy, asymptomatic patient, and makes sense,
Question number 21. Are endocrine manipulation other than abiraterone or enzalutamide still appropriate treatment for asymptomatic metastatic castration-resistant prostate cancer patients with rising PSA if abiraterone and enzalutamide are not available? Please vote. Any comment from the panel? Actually, this question, because we have to tailor the treatment according to our situation, we don't have these drugs in governmental hospitals or insurance.
It doesn't hurt to stop the treatment and see what happens, even if you're buying 1 or 2 months off any therapy that can only be good for the patient. And you're watching it closely, so if the PSA goes up after you stop bicalutamide, you can always do something about it. But if you can buy the patient 2 or 3 months without any medication, I don't think that's a bad thing.
Next question. Do you recommend regular treatment monitoring apart from clinical and laboratory assessment for M1 castration-resistant prostate cancer patients on survival prolonging therapies? Please vote. Next question. Do you recommend zoledronic acid or denosumab in hormone-sensitive M1 patients with bone mets? Please vote.
I think it's important to differentiate either alone or combined with some treatment. So alone or with chemotherapy. So
Sure, with treatment.
with treatment.
Yeah.
On the assumption to improve in survival, it does not. but to reduce skeletal events, this could be rational, I think.
Excuse me, both drugs were approved only for castrate-resistant prostate cancer. They don't approved for hormone-sensitive prostate cancer. It's a standard of care. Don't give it to patients with hormone-sensitive, and this also proved in the STEM-D studies.
Next question. Do you recommend an osteoclast-targeted therapy for castration-resistant patients without bone mets for delaying onset of metastasis? Expected answer. Last question. Do you recommend an osteoclast-targeted therapy for skeletal-related event prevention in castration-resistant prostate cancer patients with bone mets? Dr. Gamal told us the answer. Thank you. This was the last question. Thank you for the panel and for the audience.
Thank you very much. I'm asking the panelists for a group photo now. Thank you very much for this effort. And thank you, the moderators, and for preparation for this very nice recommendation. And I hope Dr. May and Professor Hisham going for manuscript process, and please circulate this to the panelists, and we try to publish it. We hope so. Thank you very much. Now we'll move to the gala dinner after the group photo. We will take the group photo first, and then ask all the participants and the audience and our professor to join us in a huge group photo. Thank you very much.